Good afternoon, everyone. And to Dr. Pickett's point, you are in for a treat today and be ready to learn. John Supra is joining us today. He is the Chief Data Officer for Prisma Health and also the Vice President of the Care Coordination Institute through Prisma. Previously, he served as the Deputy Director and Operations and Information Management Manager and the CIO for South Carolina's Department for Health and Human Services. He is driven by the belief that the health of our communities can be better through innovative uses of data and technology, which you are all about to see today. John holds bachelor's and master's degrees in engineering from the University of Colorado at Boulder. So please join me in welcoming John Supra.
Well, I like that virtual. That's very nice there. Very nice. Well, really very kind introductions. Really appreciate both Greg and Jamie the opportunity to talk and with all of you students in this program, and I know some alumni and others related to the program. We're planning on joining, and it's always a pleasure to talk about the work we're doing. As Jamie said, my role within Prisma Health is as Chief Data Officer responsible for the data and analytics, tools, infrastructure, strategy, and use across Prisma Health. And we also, I also represent the Care Coordination Institute, which is an area within Prisma Health where we focused on the value-based transition within healthcare. So as we move and take on risk, change our care models, that's an area that we do that within Prisma Health. Today, I really want to talk about how data and analytics has come to bear on our work through COVID. So I started with this idea of it may be different. And in doing that, really want to ask the question of why can it be different? I believe in really this time together. Often I've been in person with the classes at the MBA school downtown, and it's a little different for us today. We're doing this virtually. It's different for your program. Your learning over the last year has been different. It's different for your families, how you've interacted with them, how you've needed to be careful among family members, particularly those that might be at risk. It's been different for those of you that might be in full-time jobs as well. Those have looked a little different as well. And it's really been different for healthcare. We've had to react and respond in ways that in some ways we talked about, said, you know, it would be good if we did this. And in other ways, we really were just learning as COVID came into our communities and we needed to respond. So really want to talk about today of what have we learned through this period and why should it be different? Why should some of the experiences that we've had in COVID, although challenging, difficult, and for some families, households, loss of life, and at the same time, we've learned some things about the nature of work, the nature of healthcare, how we can do things that we've talked about virtually differently. So I want to spend some time really taking a data journey as my job, my responsibilities through COVID on behalf of Prisma Health and the communities in South Carolina and our partners nearby and nationwide, looking at the data as we took a journey through COVID. And as I start that, I want to talk a little bit about some things that I think are important as we consider what innovation, leadership is with a data and change-driven mindset. So there's really a healthy tension, and I'm going to talk about three areas, so that triangle. So the first area is how do our people respond to change? How do people respond to the culture? How do we set the culture? In a period like COVID, how do we as leaders enable the organization to see what is in front of us and to continue to evolve and move? In times of just innovation, how do we as leaders motivate our people, drive what would often be called change management within our culture and the people that we work with, the people we employ, and often sometimes our customers or clients that we want to move along a continuum. In processes, how we do things. So there's this tension between a history of, well, we did it this way. Well, why are we going to change that process? And what motivates and how do we lead through that? And for me, as Jamie said, my background is in technology. In addition to working in healthcare, I've worked in other industries, starting in software development, and really built my career into healthcare through application development. In technology, we can bring technology. I can buy software. We can implement that software. But if we don't change or align our processes for that same set of changes, we spend a lot of money on technology. Or we can push our people, and if we don't give them the technology, the tools, the opportunity to change process, we may be asking them to do things that they may not be successful at. So as I talk about some of the work, some of the learning, the experiences that we had within Prisma Health through COVID, I do it with this background of always thinking about, what are we asking our people to do? How are we thinking about changing our culture? What processes need to be rethought? Some of them need to be left behind. In our technology or our tools, our infrastructure, if we bring some in, are we changing our culture, how we expect things to happen in our processes? And are we aligning so that we're not trying to take old processes and make new technology fit into them? And we're really doing this in a sea of data. Our people, our processes, our technology are really awash at this point with data. And everyone wants data. Everyone says when you're the data leader for an organization, I need data. Can your team get me this data? But I think it's important to always ask the question, how is it going to change what we do? Is somebody going to use it, in our case, at the point of care to make an operational decision? And I think one of the things that's always been important, but really showed up from my perspective as we made our way through COVID, is what do we need to know about our data? Is this data directional? Does it tell us something that we better go this way versus that way? Is it good enough to answer a question? Or do we need this data to be precise? And how we operate, how we think about process change, how we inform the people that work in our organizations, those levels of data need to really be thought about. Because sometimes you've got a team that wants data that's very precise. Well, I can't use that. It isn't completely accurate and precise. Other times, well, that's good enough to make tomorrow's decision. And I think I really found myself in ourselves as an organization thinking about what data is available, how are we going to use it, and how are we going to manage from today, tomorrow, and into next week. And that's part of the journey that we experienced within our COVID response. And as we talk about some of these different areas where we use data to respond, I also want to talk about where Prisma Health is from a priority, strategy, and how I, as a data leader, have been trying to push us towards the use of data. So we use these three gears that are interconnected. Talk about leading with clinical excellence. Our role as healthcare providers is to provide the best care we can and work towards high quality outcomes for our patients, the communities we serve. We need to do it effectively or efficiently. So how do we use data to drive operational efficiency like we use data to measure how we're doing clinically? And underneath this is, how is healthcare paid for? How's the financing of healthcare changing? And in doing that, the history has been we're paid for the services, or fee for service. I said at the beginning, part of the role of the Care Coordination Institute within Prisma Health is to talk about that transition to something called value and risk. And that itself is a long conversation on a different day. But in doing that, it's really required healthcare, I believe, to drive towards standardization, think about automation, and to think about repeatability and scale in a way that healthcare hasn't been pushed to like many other industries have. We have put a lot of focus on delivering outstanding healthcare services for the care of our patients, but we've often done it in ways that are less efficient, haven't standardized across our care settings, or we haven't used technology to automate things in ways that other industries have. And as I talk about our COVID response, one of the things that I've been thinking a lot about, we've been talking a lot about, is COVID really required us to move quickly, to drive scalable solutions across all of our facilities, our hospitals, and to do it in ways that are a lot more automated and standardized than we had before. That sort of history of, well, this is the way we do things in Greenville, this is the way we do things in Columbia, and that had been part of the history of healthcare. And in healthcare, a little different than my background in technology or software, how do we start to build that notion of a safe place to experiment, to iterate, and to really drive fundamental change in healthcare? And in doing that, I think what COVID quickly pushed upon our communities and our healthcare system required us to experiment a lot more than we were comfortable with, to iterate a lot faster, and to recognize everything that we tried today may not work. And I think that's a really healthy message for healthcare, and it is for those that are driving innovation as well. So one of the first areas that we had to bring a data-informed work towards is how many cases should we expect? How quickly is this disease going to spread in our communities? And as I was thinking about this presentation, I was actually flipping through some things and thinking about this question. And this is actually a note sketch that I made, as most of the models for disease spread are designed where disease goes up and comes down somewhat on an exponential model based on a beginning point for disease spread, a rated disease spread, and that's what epidemiology models look like. Well, we're fortunate at Prisma Health. We've got great relationships with both Clemson, obviously in this conversation, the University of South Carolina, and Furman as well. So we engaged with some of our modeling colleagues at our partners. And we started asking questions. What's a little different? And I'm going to show you sort of where the real trend's headed shortly, but we were in this upward trend. And I believed, I think some others in our infectious disease group believe, it's probably not just going to fall down. We started talking about what does, and we started March, April, our first real spike in our communities within South Carolina. As I'll talk about in a second, we sort of went to July and we didn't see that one coming. My second big hump was school starting. We were concerned about that. At that time, and I think I drew this in sort of late March, early April, we sort of got to a plateau. So we started asking modeling questions. What does this mean? How do we adjust our modeling? Because it's not a typical disease spread that then falls off. So we drew this picture, and this is what we really experienced. And you'll notice that my picture is somewhere over there in April, and this runs out to early February. I think I grabbed this from. And you see the picture I drew really went to, we were on that plateau at the very beginning where the population, and this is across all of the Prisma Health facilities, was about 100 and stabilized for almost 2 months. Well, in late June, we saw this uptick. I think people had moved to school online and virtually. A lot of businesses were shut down in that period. And as summer came, some things loosened up. And the 4th of July came, and we were reacting to this sudden climb that, as you could see, the modeling we did wasn't where we were modeling. We weren't aligned to that. And we saw a peak that we thought was a pretty significant peak across all our facilities at about 320 patients. and it dropped off again quickly. And then we sort of bounced around for another 1 to 2.5 months. And we thought managing 100 patients was a challenge with COVID in our facilities. We thought managing 300 was. And coming out of the Thanksgiving holiday and into early January, we then saw a peak in about 550. I think the number there is 548. So each one of these represented a new look at the modeling. We built on the learning we had in the data side. Our care teams built on the experience they had. So then managing 100 and some patients in that steady state in September and October felt a lot easier than it did in April and May. The roll up into 200 and 300 felt okay. And then we had to learn again to manage 500 patients. And we've seen a fall off, and we're fortunate for that. And we continue to look at what are we learning from both the care model and the mathematical or the data modeling to understand what the future might be as we introduce vaccines, as we continue to do care in our communities. We also asked a question in that first, at the end of that first sort of first hump. Well, we know masking is important. Can we afford, and if you recall back, access to masks were a scarcity. We were fortunate to have a good supply. We were fortunate to do okay with a great supply team through all of this. But should we mask everyone that was walking into our hospitals? Should we be reducing the people we allow to walk into our hospitals? How about our practices? So we really had to think about and make a decision that the challenge was, can we make this decision by next week? And that required a set of data thinking that really we weren't that comfortable with. A lot of people are like, well, we need to know precisely, going back to a precise number. Now there's us where, well, we need directionally correct because the order of magnitude of masks here is in the hundreds of thousands and low millions. So how do we allocate our resources? How do you understand that you're going to have significant unknowns in the problem set, but you've got to make your best proxies because we need to make a decision that impacts all of our facilities and our supply chain on short order. And we need to take a little amount of data, some common sense in the history to understand that if we wait till this is precise and perfect, a lot more COVID is going to happen. So we made decisions and learned how to model a lot faster than this organization really ever had. We figured out how to take the inputs, how to figure out those outputs, and keeping that notion of what really matters. How do we then go out into the field, do some sampling at our hospitals to figure out, are these assumptions fair? And then build a model that really challenged our traditional thinking towards iteration. And along the way, and you saw that we talked a little bit about teams, it was new to our organization at the time. So I could engage all of our hospitals. So people at every hospital could provide us some input for what was going on the ground, and we could improve the model. So although this type of thinking is common across many industries, applying it to the decision around masking for a health system looked and felt a little different. We also, and you may think back to that period probably in late April and May, there weren't a lot of testing resources. So we didn't have access to a lot of community testing. The challenge question was, with limited testing resources, where should we go out into the community to test for COVID? And that had a lot of inputs. We needed to understand where were patients already coming from. Well, we knew who we had in the hospitals, so we used that data. We also, and as you've continued to see, certain groups are at greater risk, groups based on age demographics, based on, and I'll use the term social vulnerability, those people that may be food insecure. housing insecure. We also know that COVID has not affected races or has affected races and ethnicities in different ways. So we took all of that data to build a model along with some commercial data we had about income, working down at the census tract level to start to make recommendations and decisions about where have we seen COVID spread already coming into our hospitals or emergency rooms? What do we know about the underlying health conditions and the economic or social determinant conditions of our various communities so we could prioritize where we went for testing? It proved to be very helpful. We were able to get into communities that I think we needed to be in, and we used that process all the way through the summer to make determinations until there really was enough testing in the community about where Prisma Health took its limited community testing resources. This is an example. This is one of the geomaps in one of our dashboards that we built. We started just populating this, and this can zoom all the way in for all of the tests we've done. I think we've done over 250,000 COVID tests across our footprint. And I said, things can be different. I don't think anyone here would be surprised that video visits make a lot of sense, particularly when a provider may not need to put their hands on a patient. An automated symptom checker. When people were in our hospitals and we needed to limit visitors, how do we bring a collection of iPads so patients and families can remain connected? We built an application that allowed, after both discharge and for those people that might have shown up with mild cases or symptoms of COVID, either in our emergency room, but were safe to be discharged, or in our practices, a self-service follow-up app to deal with the volume. It forced us, perhaps, to think about ED virtual visits and really led us to now offering 24/7 visits to what are have been our MD 360s or our Prisma Health urgent cares, now available. Home monitoring. Some of those people that either had chronic conditions that normally would come into our practices, we needed to find ways to support them. And we also took, for some of our care, some text-based reminders. So all of these things are probably not a surprise to many of you because they're how you interact with many businesses. But healthcare sort of needed a real motivation to take things we might have piloted, things we might have tested, and to actually, within Prisma Health, take what was about 30,000 of those events, what is now 2 years ago, to really having nearly 600,000 virtual encounters in this year since COVID started in our communities. So a significant change to how we deliver care. And this is just what one of our patients provided feedback to us. The comfort of being cared for, knowing that they were safe, not having to come into facilities. And as I said, we lead with clinical excellence or quality. We still were needed to report a lot of our quality metrics that we were providing care for. And our teams rallied around reaching out to patients virtually through phone calls to ensure that we could connect with them, make sure they had the medicines they needed if that's what they needed, and continue that quality work. And in many of the areas, we remained in that top quartile and decile quality that we strive for within Prisma Health. So virtual care, not a surprise to anyone, but for Prisma Health and for many healthcare providers, it really accelerated what had been worked on, had been piloted, in lots of culture, lots of process saying we can't do it that way. Well, it really became a necessity, and it was done that way, and it will continue. And then we got to vaccines. And the task in front of us was to deliver vaccines as quickly as we could. And I think everyone knows, understands the supply remains challenging. Prisma Health in early February delivered the 100,000th vaccine within the state. This is as of last night. We had delivered 187,000 vaccines, first and second doses. But this dashboard, this is one part of our dashboard that was built within days. Something that we might have created a big project around, might have got a lot of people, well, what do we think about it? What should we do? Well, on day one, it just kept track of how many doses we gave, how many of them were our employees or our own team members, how many second doses, which weren't that many at the time. But every day that we had another question over really the last month or so, we continued to ask or add to this dashboard. It has tabs that include, like the testing, a census tract level of where those that have been vaccinated, the gaps between our first and second doses is used for our teams for outreach, and really looks at this movement from no vaccines on, I guess, our first one on December 18th to nearly 200,000 within the Prisma footprint as of last night. So I guess we'll get up to a little bit more. So I think the answer is it clearly has been different. It's been different in all of your lives. It's been different for a healthcare system. And in doing that, I think it challenges us to ask the question of how do we continue to move in new directions? How do we think about the notion of what have we learned very quickly in COVID? What was sort of simmering in the background? And what do we need to continue to accelerate to bring better health to, in our case, the citizens of upstate Midlands and throughout South Carolina? And I think, and I've talked a lot about COVID being an accelerant to the work we do about improving our clinical quality, a different patient experience. That 2 years ago, we would have been sitting around a conference table talking about can and should we, not we needed to, and we figured out how to do it. And I hope that all of this continues to drive access to affordable health care, and it has challenged us absolutely to think about how we operate, what's necessary, where can we use technology, where can we be willing to change process, and it has come at a lot of cultural change in response to COVID. So as we think about that, I want to leave you with a handful of ideas that as innovators, as people interested in data and analytics, and as leaders. So one of them is, and one of the things that the team here hears me say a lot about, are naked numbers. I hope that throughout this, I talked about, we had about 30,000 virtual visits and we got to 600,000. So one of the things that I think is important as a data and analytics leader, innovator, is to always be asking the question about what is that denominator? If I left a number naked, you should be challenging me. You should be asking about, well, what is that in comparison to? And I picked this up. I don't know if any of you are familiar with the factfulness and Hans Rosling, a Swedish healthcare and statistician. And he talks a lot about this notion of if we don't know what it's in comparison to, 600,000 might have felt like a lot of virtual visits. But if I told you we did 500,000 last year, that's not much of a change. Its value comes in the growth from 30 to 600. So how do you put numbers in context as a data and analytics leader? And another concept, or that same idea, another book you may be interested in, Naked Statistics. And I really like these ideas around that data and analytics has as much art and investigation as it does simply the math, addition, or long division. So thinking about and aligned to the ideas of naked numbers, important to think about what is the power of statistics. And again, for anyone that wants a career both in innovation and data and analytics and television, maybe CSI regression analysis is for you as well. And I don't know if any of you have ever seen this book. This is actually an older book. I think maybe 2012, 2013. WordPress, the blogging platform or website platform, is famous for being virtual. Its organization is almost 100% virtual. They meet in a structured way, but I think a lot of people have learned to respond to these shifts in the nature of work. Scott joined WordPress for a year and talked about what it was like to work from home over a year, to do the meetups that WordPress does. And as I was thinking about what have we learned about the nature of work, I went back to that to say, well, there's some companies that have been doing this, and they're good examples of some of the structure that as we think about bringing people back to offices, thinking about hybrid approaches, thinking about virtual approaches, what have we learned as leaders in how we use the technology tools to support a work environment in productivity? So something to think about there as well. And I don't know, some of you may be familiar with the Masters of Scale podcast series. Early on and through the summer, they did a COVID response, and they talked to innovators across a number of industries on how this was affecting their businesses, how it forced them to think differently. And you see one of the ones I included was the Automatic is actually the parent company to WordPress. The Automatic co-founder is they had a culture of remote work, and what could we learn from it? How did Airbnb have to think about what the differences in their world were as people stopped traveling? And you may be aware that they were on the verge of a public offering. I think they were originally slated for May or June. So a whole series that I found and I've shared with my teams around what does this make us think about as healthcare providers delivering services and responding quickly. How does it align to other industries? And what is it telling us about how we want to change coming out of this pandemic? And as I said, we've delivered almost 200,000 vaccines. And it also required us, because we needed to do it quickly, to stand up some large facilities. Here in the upstate, we have a facility at the Kmart, the old Kmart, across the street from our Greenville Memorial Hospital. This is the site at Gamecock Park, adjacent to the stadium in Columbia, that is a drive-through site. And we took many of our staff that were not already involved in patient care, and we brought them. This is a comment from one of our corporate nurses that works on our team. She focuses today on post-acute or post-hospital stay work, but she was on the front lines delivering vaccines. And we have stories like this to share. And it's been really powerful for an entire organization to get behind when we were coming out of that high of 500 people across our facilities, straining our resources, and also leaning into starting to vaccinate in our communities. And you might have seen, this is the oldest South Carolinian. Her and her daughter, who was also over 70, got vaccinated together. And I was actually told earlier today that they're returning to the Kmart site today for their second dose as well. So I didn't even know that this morning, so a little added for a conversation today. And these are the words she shared at the vaccination site. So we've seen a lot through COVID. And you may recall, for those that may have a little bit of stargazing or otherwise, over the winter solstice, and this is a picture of Saturn and Jupiter, and you can zoom in and I can make that distinction. They came very close together. So this experience over the last year, in some ways, I think we hope it's a once in a lifetime experience for many of us. I think there's a lot of lessons learned for healthcare, for many industries, for all of us individually. It's been definitely full of some grief and some challenges. It's also given us opportunities to think differently. So with that, my final thing is the CCI team. If you're interested in the sort of transformation of healthcare that I've been talking about, the data and analytics that support that, We do hold a symposium annually. We postponed, that's better than the word canceled, last year's. We are hopeful and optimistic that we'll be able to do this as a mostly in-person event in the fall here in Greenville. If you have any questions about data analytics, care transformation, happy to talk with you as well. We invite you to our symposium. The team at the MBA program is always aware of it. And I really just appreciate the time and opportunity to talk to you from that lens of it was very different. And I hope that this gave you an opportunity to understand how it was different from the lens of a large healthcare system, from a person responsible for data, in using and bringing to bear the data that was available to us in some very rapid ways to frame, to inform, to support our response as Prisma Health to COVID in our communities. So thank you. So with that, I'm happy to answer, respond to any questions.
Thank you, John. Carlos, you have a question in the chat. Do you want to go ahead and unmute and ask?
Sure, I actually have to. I just came up with another question. So, yeah, no, that's great because I have some typos on that question in the chat. So, yeah, so no, that was a great presentation, I thought. So what I wanted to ask, I'm just going to summarize it. I mean, you know, just in this class, we'll learn about a lot of techniques, a lot of different things that we can do with data now, as opposed to 20, 30 years ago. We made a lot of advances in that respect, but you know, I think with, you know, a year ago since the pandemic started, a common theme in, you know, in some areas, some sectors of our society is reluctance to believe in the data. You know, there is, you know, some people don't trust what's put out there. So, you know, my question to you as a data professional, as a data provider, is what will you do to change that perception and to be able to make people feel more comfortable with looking at the data and trusting it?
No, that's a great question. And there's probably multiple layers to that. So within the work that I and our teams do, you know, I'm going to start sort of internally in that notion of within a health system, I don't know if so much the trust of the data becomes the question, but how do you start to build a culture that makes decisions around the data? So I think in one hand, this idea of is data and analytics leaders, along with doing the work, and I liked where you started, this is sort of the message about what's the difference between the technology and the tools and the people and the culture. So on one hand, we have a responsibility to educate our organizations around the use of data. And I like to use the language of data-informed culture. So internally, we have to do that. As we go into our communities, and you're touching on, and I think we're seeing it with the vaccine greatly as well, you're touching on how do we have a role, not just as data, but in healthcare, to do a lot of education and to be able to bring data and information to the level of the audience, the group you're talking with. And I ultimately believe that we need a lot more of this in our culture broadly. So there is a whole other push that we have to bring a lot more data and analytics thinking into our education system. And one of the benefits of the tools, as you've talked about, is it usually would be a path of, I would have to be decent at math. I'd have to then get committed to some really high level math before somebody's going to let me do all that much data and analytics. A lot of the tools allow us to visually have people work with data to answer some of their own questions a little before they even have to understand all the math. Some people will go on and continue and probably be data and analytics leaders, but we need a much greater data-informed culture in society. And I think ultimately it's got to start with how we educate. We need to engage with math and science a lot stronger than we are. through our entire education right now. So I know that sounds very lofty, but I don't know how else to get there. And it's going to be something we commit to over time.
No, I totally agree. I think other countries have a very, very strong emphasis in math and science, and I think we have fallen behind a few places of what we used to score in that category. So another question I had was as far as Prisma itself, this is unprecedented, right? The entire COVID pandemic thing, and but as an organization, do you think Prisma, your current analytics infrastructure, do you think it was adequate? Do you think was there anything new that you learned as far as the way that the analytics process should be performed? Or can you say, no, you know what, our current infrastructure was able and was ready to handle the kind of analytical exercises that we needed to conduct to reach our goals?
Yeah, great question. So definitely not ready and definitely not adequate in lots of different ways. So the teams that I'm responsible for, we are actually in the middle of a migration to a more modern, some of you may be familiar with the Snowflake cloud data technologies. So we've been in a migration to that. We are immature. Those dashboards that I showed you pieces of throughout the presentation, we had capabilities, but we really had to push to get dashboards quickly enough. So like our virtual care, we had pieces of a direction, but we were on a roadmap that was way too slow for the response to COVID. So I think we were not prepared, not adequate. Healthcare broadly is not nearly as agile as other industries. I think we've hidden behind healthcare broadly the protection of data and not found the right balance of protecting data in a responsible way and making use of it to move quickly. And we've been slow to bring cloud technologies and modern application development methodologies to healthcare. And I say to Prisma, healthcare broadly, other systems like us, the payer side, the insurance, all of those share that. Healthcare has not been highly interoperable. So it was a challenge to get data that wasn't just Prisma Health data to look around our community. In the public health sector, we recognize that, and I think you'll see changes there. Standardization I talked about. What we realized is we could build dashboards up here that rolled up Prisma Health data, but then we had people doing processes slightly differently, and we didn't realize that until we saw discrepancies in data. So we used that as a learning opportunity to drive standardization. So I don't think prepared. I think we were on a path moving slowly, and I would say very similar to our virtual care. And this accelerated it, and it's actually informed our continued investment. So that's been a benefit through my lens, through all of this. So, good. There was a question on the drop of in-person visits. I don't know that number off the top of my head. I can get back to it. We had a drop really in that April-May time period, and then a little bit in that July. In that last surge, we were able to manage our hospitals and maintain our practices. I think overall, there was a drop in our in-person visits, but it was not as material as we might have expected. So I'll be happy to grab that and get back to somebody so that you have a sense of that answer. So. Anything else?
Yes, hi. I had a question, and I am an alumni. I actually had the opportunity to attend the CCI symposium last year, and it was a very enjoyable experience. I recommend it to anyone that's able to attend this fall. Hopefully it's in person. My question was regarding the ease of collecting data now and how important it is. I know you mentioned data security, but just wanted to know, what criteria do you use to determine what data is meaningful to make future decisions?
That's a great question. So given cloud technologies, I think it's less on the collecting side and more about how do you use the data to figure out what is meaningful. So I would say that we lean towards over collect, and we don't use everything we collect, but we have built infrastructure, and that's one of the benefits of going to a cloud-based both storage, analytic, and computing model, that when we go back and we say, look, we didn't grab this information, but we had it in the raw data, let's bring it over and analyze this problem in a different way. So I think in a lot of ways, it's that question of get what you can, and we're often collecting from lots of systems, store it in an organized way, and understand that you can use and reuse it. I think there's a slightly different question around if you're doing survey work, public health work, and that's something that we saw ourselves having to get a lot more into. You really got to be able to think about your sampling, and that's how I work with our university partners to understand those methodologies, because we don't have complete data. You know, when we deliver care, we're responsible for that data. When we work in what are called our networks, we're responsible for that data. But when we've moved into this COVID work, it's been a lot more like working in public health. So I think one of the other learnings, myself, some of our other leaders, are how do we think about the role of the provider in public health in a way that we probably hadn't been prior to the pandemic as well.
Okay, thank you. Yes, I think there's a big push towards just cloud computing because of the flexibility and scalability of it. So I really hope it's a smooth transition.
Yeah, we've made that transition fully to Snowflake. We came off of Oracle. We did that in the middle of this. Our team, that part of the team stayed very focused. They were right on schedule. We've done some amazing things. Our work with Snowflake, we're seeing about 50% total cost of care relative to running Oracle historically. And we have the capability, because it's fully elastic, to do things we couldn't do. We make a mistake with a data analysis, we could rerun that overnight, where before it would have been a week or a month for us to be able to get back to that point. So I'm thrilled with it. I think for the learning all of you are doing, data and analytics is a cloud business, needs to be an elastic cloud business. Healthcare needs to understand how to manage and run it securely and safely, but without that power, the work that we need to do is not possible. So I'm excited about our journey there.
Thank you.
Yeah. I've got three, last one is a thank you. So thank you for the, thanks for the thanks at the bottom. Hiring in our department. A lot of this is about that willingness or openness to be curious. I think willing to try and going back and thinking about that slide that was sort of, I don't know, in about a quarter of the way in. Try, iterate, be okay with failing. Understand this is an experiment. Be able to understand what is a good experiment and a smart experiment and what's not. Being able to make connections across things that other people aren't connecting sometimes. Understanding healthcare is important, but we actually can teach people about the data of healthcare. It's a lot harder to teach people how to be curious, how to be inquisitive, how to say that, look, if we think about this tool and we're willing to change this process, we could get a different outcome. So really want to challenge people when we talk to them, how do they think about problems that there aren't easy answers to? The work that we do in data and analytics on behalf of Prisma, and particularly in the CCI, if there were easy answers, they're probably not problems we're working on, because there's easy to get reports about those things. We're really challenging ourselves to think about, as a healthcare services provider that used to deliver a service and get paid for it, needs to take on risk, needs to think about its role in public health within the community, needs to engage with employers for the health and well-being of their team members. How do we think about that? And we refer to that, and you'll probably hear some of the other Prisma Health leaders talk about being a health company. We are interested in the health and well-being of the communities we serve, the Midlands, the Upstate, the state of South Carolina, and with partners across the region. So that's a real shift. And for people thinking about that, how do you engage with that very big picture thinking and be able to turn that into tactical? There was a question I know I saw about convincing people on the vaccine. It's really hard. A lot of ingrained cultural community education. The work that we've been doing is to find people that are positive about the vaccine already in the community that people can relate to. It's very hard to come into a community as the health professionals and say, yes, this is good for you. But how do we work with the local community leaders? Be those leaders in the community, in neighborhoods, places of faith, community centers, and let them ask us questions. Let us provide information to them. And if they are believers in the vaccine or skeptical and we can educate them, that's been our best work. And that's, again, a reiteration of that's on the ground public health work. And I think we've really seen that that's critically important as well. So anything else? Reacted to the virus. That's probably a long one. I think there's questions of how is public health and the health systems reacted. I think we've done okay. I think our community, we've been a community and we are a state by all regards that has balanced this social liberty with public or community health. And I think that's been a challenge as well. We've probably reacted with policy a little slower than some other states. And I think that's part of who the state is. And I think it's part of who the region is. And I think, and we talk about being proud of the work that the men and women of Prisma Health have done to serve the community. So I think that that's a really hard question because I think there's a lot of aspects to it.
All right. As much as I hate it,
I appreciate that. So yeah, I'll turn it back over as we're at the top of the hour and really appreciative of the time and opportunity to speak with all of you.
Great. Thank you so much for the information, John. It was fabulous as usual. So thanks for sharing with all the students and alumni and community. So appreciate it.
Very good. Thank you all. Take care.
Thanks, John. Take care, everybody.